Good morning. Good morning, Madhu.
Good morning, good morning, good morning.
Can't hear you. 1 minute.
Oh, how are things? Subhash? So you have not seen the video.
Hello.
Hello?
Can you hear me, Madhu?
Yeah, I can hear you.
Okay. Done. We are fine now. We are fine. You know, our system also sometimes becomes like a neurology case. Where where we can't find where is the block. Yeah. So great. How are Madhu? Everything
Yeah,
fine?
fine, doing fine, no problem.
Good.
Do you think that we should change the timing so that many people can, is it like that?
No.
It's all right, no?
It's all right. You know, I have an experience of 30 years in this timing business now. I was dean of Nizam Institute so at 8 o'clock our class used to start, people would come at 8:30. Then my directors told me, should we keep it at 8:30? We kept it at 8:30, they would start coming at 9. This is our human psychology. We have gone through it. So this is the ideal time because it
I
makes
think,
you
sir,
feel
Madhu
Yes.
sir, I think it's better that you change the time because people go for rounds at this time, and many of my friends have told me that they find it difficult to attend at 9.
Okay.
well, I don't think it will work, but you can try it. You can try it.
Now, initially it was at 10 o'clock, I think. Initially, I changed to 9 o'clock because of the masterclass program. It was coinciding with the time. That is why I changed when preceded the time.
Is a masterclass still there?
No, it's over now. Masterclass is over now.
Master class is not there, but the morning rounds are not uniformly held all over the country at the same time. I know some places where morning rounds take place from 10 to 12. I know some place where they take from 9 to 10. So, you know, it's not a uniform time and in whole of country. But you can always try and change. That's not a problem. But the other thing is you can make it 7 to 8 in the morning. But then people will say that we are spoiling the Sunday.
That's correct. 78 will be problem for many. But beginning Sunday, no, they get up late and leisurely enjoy in the morning. So we'll ask Sudhir whether to change time or continue with this 9 o'clock, no problem.
Sudhir will tell you, you decide. You ask other. No, but Sudhir can do one thing,
Yeah.
which Sudhir knows. He's very good at conducting polling.
Yeah.
You know, through this he will do a polling. In
Okay.
some polling, he'll come to know.
Okay.
So
Okay.
yeah, that is. I think he's the best person to decide.
Mhm.
I can contact him and ask him to do a survey. He'll do a
Yeah,
survey.
because he's
Sir, 9:30 would be slightly better. That's what I feel because it will be too early, 9 o'clock. So,
9:30 and 10 does not make a difference.
oh,
Let us- yeah.
I mean, if you are comfortable with the 9 survey, we can go ahead.
I am
Then,
comfortable with any time, no problem.
okay, then
Madhu,
Yeah,
Madhu.
tell me, Subhash.
My question to you is,
Uh,
but don't laugh at that question.
uh,
Don't you go for morning rounds?
uh, I don't go for rounds on Sunday. I take full day leave on Sunday. I don't go to hospital, do anything on Sunday.
That is because of your seniority.
Yeah, correct.
Yeah, I think George, they have exempted me also from the morning rounds, but most of people have to go for morning rounds. That's true. But then what time to do? I think Sudhir can do a survey, and
Yeah.
that is the best thing, and he will like it. He will like
Okay.
to do the survey. He loves surveys.
In a way, this is good time, sir. Those who wish to have it and they can go for some other purpose also. By 10, 10:30 it will be done. And anyhow, people should take some time. If they are ready, let them take the time. Whichever is convenient, we are ready, sir.
Okay.
Whichever is, even if it is 6 o'clock, we are ready.
So shall we start?
Yes,
Yes,
sir.
sir. Yes, sir. Yes, sir.
Yeah. So good morning to all. This is the 52nd session on this challenging case series. I will start my share screening. Is my screen visible?
Yes, sir.
Yeah.
Okay, right. As usual, I start with a short. This is not a very short case. Little less short than before previous cases. This is a story of a 6-year-old man. Is there echo coming from my talk? When you talk, is there echo coming?
Yes, sir, your echo is coming, sir.
Okay, then I will do one thing. I will switch it off and then play my screen. Story of a 6-year-old man, instead of having had fall from the bike with right shoulder hitting the ground 8 months back. I think the echo is still there, no?
Yes, a little bit.
Do one thing. I will then share the screen once again. Screen is visible now, no?
Yeah.
Yeah, the
Yes.
echo is there. Anyway, it doesn't matter. Okay, this is the story of a 6-year-old man is having had fall from the bike with right shoulder hitting the ground 8 months back. He was found to have shoulder dislocation and fracture of the clavicle, for which surgery was. Since the time of accident, he was not able to move his right upper limb, which remained like that except for mild improvement in the shoulder movement. He was referred to me by the orthopedist to find out whether he requires an restoration or wait for recovery. This is a usual problem which all come across in practice. The orthopedist referring to a case of trauma, like plexus surgery or root ablation, whatever it is, to find out whether to intervene or not. So this one such case. This is the discharge summary from the orthopedician. Type 2 diabetes mellitus, injury to the brachial plexus, initial encounter, person injured in unsuspected motor vehicle accident, dislocation of the pedic right shoulder girdle, and specific injury to the right denominator subclavian nerve. This is the initial diagnosis they had at the discharge center. This is the video of the patient. അങ്ങനെ വിടും. ഇനി അടുത്തത് ഞാൻ ശ്രദ്ധിച്ച് കേൾക്കണേ. ഇതിങ്ങനെ പിടിച്ച് നിർത്താൻ നോക്കണേ. പറ്റണില്ല. ഓക്കെ, കുഴപ്പമില്ല. ഇനി വെളിയിലോട്ട് എടുക്കണം. ഈ കൈ ഇങ്ങനെ വരണം. പറ്റണില്ല. ഇത് വെളിയിലോട്ടെടുത്ത് മനസ്സിക്ക് അതേപോലെ ഈ കമ്പ് നടക്കുന്ന പറ്റണില്ല. കുഴപ്പമില്ല. ഇനി ഈ കൈ പിടിക്കണേ. അതേമാതിരി ഇത് നോക്കി പിടിക്കണം. ഇല്ല, ഇനി കൈകൾ വെളിയിലോട്ട് തള്ളു. ദാറ്റ്സ് ഗുഡ്. ഒന്ന് തള്ളിക്ക് പറ്റും. അതിന് പിടിച്ചോ. ദാറ്റ് ഇസ് ഗുഡ്. 3 ഉണ്ടെങ്കിൽ ഇനി ഇത് പൊക്കി പിടിക്കും. വിട്ടോ. ഇതും പൊക്കിക്ക് നോക്കട്ടെ. പറ്റണില്ല. ഇത് പൊങ്ങട്ടെ. പറ്റണില്ല. ഇത് കണ്ട ഇത് മടക്കാൻ നോക്കിക്ക്. മടക്കിക്ക് അകത്തോട്ട് മടക്കി പിടിക്കും. കണ്ടോ? അതേപോലെ ഈ വെല്ല് മടക്കിക്ക്. ഈ തള്ളവരിൽ മുകളിലോട്ട് എടുത്ത് ഇത് അകത്തോട്ട് ഈ വെട്ടിന് ആദ്യം വെളിയിൽ മടക്ക്. അറ്റ മടക്ക്. ഓക്കെ. പിന്നെ താഴെ വെച്ചിട്ട് അകത്താൻ പറ്റി നോക്ക്. അകത്തേക്ക് അടുപ്പിച്ച് ഇല്ല. ശരി. ഈ കൈ ഇങ്ങനെ വരണം. ഇങ്ങനെ കൈ അകത്തോട്ട് കൊണ്ടുവന്നു. ഈ തോട് കൈ ഇങ്ങോട്ട് അങ്ങോട്ട് തള്ളിക്ക്. അങ്ങനെ അതേമാതിരി ഈ കൈ നെഞ്ചിലോട് ഇരിക്കണം. അങ്ങോട്ട് നെഞ്ചോട് ചേർന്നിരിക്കണം. ഈ ഭാഗം അങ്ങോട്ട് നിർത്തി. Don't hold the hand in the correct position because of the severe weakness of the biceps. Get the other hand. Right biceps is absent. Left biceps is normal. Left superior is also normal. Right superior is absent. Right biceps. Left triceps also is absent. Nothing in the lower limbs.
അറിയാമല്ലോ. അറിയാം.
Able to feel there. Able to feel there.
ഇതോ
Not there. It's not
അറിയാമെങ്കിൽ അറിയാം, ഇല്ലെങ്കിൽ
pain below the
അറിയുന്നില്ല. ഇതോ
ചെറുതായിട്ടറിയാം.
ചെറുതായിട്ട്. ഇതോ ഇല്ല.
അറിയാം, വേദന എടുക്കുന്നുണ്ട്.
ഉണ്ടല്ലോ. അറിയാവോ? കുറവാണ്. ഇനി അറിയുമ്പം പറയണം. നന്നായിട്ട് അറിയും. ഇതേപോലെ അറിയുമ്പം പറയണം.
when he feels it.
ശ്രദ്ധിച്ചിരിക്കണേ.
അറിയാം.
Here he is able to.
ഇനി അറിയുമ്പം പറയണം.
അറിയാം.
We can't able to.
ഇതൊക്കെ അറിയാം.
അറിയാം.
ഇതൊക്കെ അറിയാം.
അറിയാം.
ഇതും അറിയാം.
അറിയാം.
ഇപ്പം എന്തെങ്കിലും തോന്നുന്നുണ്ടോ കിരികിരാന്ന്? കിരിയിൽ പറയുന്നുണ്ടോ?
ചെറുതായിട്ട്.
ഇതറിയാം.
Not in the wrist.
ഇത് ഇവിടെ ഇല്ല.
അറിയാം. അറിയാം.
ഇത് അറിയുന്നുണ്ടോ?
കിരികിരാന്നറിയാം.
ഇപ്പോഴോ
It's
അറിയാമോ?
അറിയാം.
ഇതോ
the hands.
അറിയാം. അതുപോലെ
The external rotator is a little bit as good.
ഇങ്ങോട്ട് കൈ വിട്ട് ഞാൻ പിടിച്ചു. ഇങ്ങോട്ട് തള്ളാൻ നോക്കിക്കേ. വെളിയിലോട്ട് ഈ കൈ ഇങ്ങോട്ട് വരണം. ഇങ്ങോട്ട് എൻ്റെ ഇങ്ങോട്ട് വരാൻ നോക്കിക്കേ. പറ്റണേ. പറ്റുന്നുണ്ട്. ഒന്നുകൂടെ. അങ്ങനെ ഒന്നുകൂടെ. ഓക്കെ. ഈ ഷോൾഡർ ഒന്നുകൂടെ വെളിയിലോട്ട് കൊണ്ടുവന്ന്. ഓക്കെ, മതി. ഇങ്ങോട്ട്.
So an examination power, grade 2 for the right deltoid, external rotators and triceps. Grade 0 for right biceps, supinator, pronators, all wrist muscles, finger muscles, and small muscles. All absent on the right upper limb. Biceps supinator normal on the left side, triceps absent on the left side. Sensory dulling over the right forearm up to the elbow. vibration separation all over the right upper limb, but much less than on the left side. So where do you think it's the localization? Because here our task is to whether we have to submit the patient for pre-surgery or not. So where is the site of lesion and what will you advise the surgeon?
Sir, it's looks like in the roots
Okay, radicular possibility, yes.
or the proximal part of the brachial plexus. That's what I mean. Proximal at the level of the root level of the brachial plexus.
Root of the brachial plexus. Okay.
Root of
Okay.
How long after the incident is a
This
patient
is-
seen by you, sir?
This is 8 months after the accident. 8 months after the surgery. 8 months.
Since the external rotators are weak, I would consider a possibility of proximal the root of the brachial plexus on the right side.
Okay. So we'll wait. Let the other people also give their answer.
Madhu, does he have still pain?
He has no pain now.
Okay.
He come with only the weakness is persisting.
Could we test the serratus and the rhomboids?
Serratus was normal.
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 And rhomboids?
Rhomboids I did not test.
Yeah, so it could be the just, distal to the roots of the brachial plexus.
Okay. Right. Anyone else want to give an opinion?
Chord of the medial cord, posterior cord.
Yeah. Is it Bindu speaking?
Yes, sir.
Yeah. Bindu, tell me once again, medial cord and
Posterior cord, sir. And half of the lateral cord, like the patient is having the
so
tension was up to the lateral part of the.
you think the lesion is likely to be in the cord level, right?
Yes, sir.
Okay, correct. Okay, let us come to the point once again. See, it's not a radiculopathy. Obviously not radiculopathy. Why not radiculopathy? Not only because lattice anterior is paid. Look at the distribution of the weakness. It's got zero power on the biceps and supinatum, but grade 2 to 3 power of the external rotatus deltoid. So that means it is not in the root. You can say partial effect of the root, you can say. But let's take it with radiculopathy, because radiculopathy of C5, C6 should produce weakness external rotatus and deltoid more than the biceps. So that's not a radiculopathy. So then this is the point which I have made. Then cannot explain by a C7 root explain the severe weakness of the wrist sections of the finger extensions because biceps is relatively spare. That's another point favoring against radiculopathy. If you implicate C7 root involvement to account for the zero power of the wrist extensors and finger extensors, triceps should have also been weak. That is relatively spare. So you can always argue it may be partial affection, but you are thinking more logically, it is distal to the root. However, C8 root can explain the weakness of wrist flexion, finger flexion, and all small muscles of the hand. That part you can explain the root, but not the rest of the muscles. Now, can the lesion be at the trunk level? Anyone votes for a trunk level of the brachial plexus?
It means there should be more uniform involvement rather than a patchy, sir.
Yeah, and of course, what you said is correct. But if you imagine that it's a complete affection, is there can it be a trunk level by any means? The same point arguing against the trunk level. Suppose if you think, can we explain the weakness of the biceps supinated due to an upper trunk? Each could weakness of biceps supinated. That is separated by the upper trunk. Okay, but it is not in the upper trunk because deltoid is paired, its external rotatus is paired. So C5, C6 roots form the upper trunk. So the pattern of involvement of C7, C5, C6 exactly mimics that of the trunk, upper trunk, except for the serratus anterior. So here also there is a disparity in the power between the biceps and the deltoid. So that tells you it's less likely to be in the trunk level, unless you think of a partial upper trunk involvement. The latest sparing the deltoid and external with zero for the biceps. You can argue that may be partial effect of the upper trunk. Now, why I am asking you like this? Because this is very important because for the surgeon to operate on. Because even after 8 months, there is no recovery, zero power. That means he should undergo surgery. If a 2 power is there, still he not undergo surgery. So you must know exact localization. Now, can you explain the weakness of the wrist extensions, finger extensions by middle trunk lesion? Anything against a middle trunk?
Triceps is
Yes,
spared.
yes. So you should have produced weakness of the triceps. So you can't explain the middle trunk lesion. Can we explain the weakness of the wrist flexion, finger flexion, all small muscles by lower trunk? Yes. That part can be explained with that lower trunk. So if you think of a trunk level, you can explain only the some muscle involvement. But you can't explain the muscle involvement by an upper and middle. Only part of that upper and middle trunks are affected. So unless you think of a partial affection, you cannot localize it to the trunk level. Okay. So let's come to the cord lesion. Let us take the lateral cord. We can explain the weakness of the biceps, wrist flexion, pronation by lateral cord, and sparing in the deltoid can be explained by that. Let us take the posterior cord now. We can explain the weakness of the wrist extensors, finger extensor by the middle trunk lesion, but it should not produce, it should have produced weakness of the one, produce deltoid triceps at a similar degree. You got the point. You can't explain by a posterior cord. The posterior cord is supplying the deltoid, which is spared, relatively spared here. Triceps, that is also relatively spared.
That may be a distal lesion, distal to deltoid.
That means it becomes a radial nerve. I'll come to that. That becomes radial nerve. Now let us see the medial cord. Everything can be there. The other muscles can be separated. Just to make you see earlier, the muscles in the hand, etc., can be separated. Lesion can be in the lower trunk, can be in the CA, even radiculopathy or a medial cord. All behaves the same, exactly the same, except for the extensor releases weakness. So that you can explain very well by the medial cord. So all muscles supply can be explained by the lateral cord and medial cord, and part of the posterior cord or distal part of the posterior cord, there is a radial nerve involvement. That way you can argue, explain in this patient, or it should be partial effect on the brachial plexus. Can be at the nerve level, very unlikely, because we have to implicate median, ulnar, radial, musculocutaneous, median, lateral, antebrachial. So all rest of the upper limbs affected means very logically unlikely. Know what? So the most likely localization, one partial affection the pan-brachial plexus, which is logically less likely. The other possibility is affection of the lateral medial cord and radial nerve above the elbow in the spiral group, sparing the deltoid. That's the way you can explain in this patient.
Can all those happen at the same level lesion on the arm?
No, we don't know because this all happened following the accident. So we have to, the accident can produce what sort of injury he had during the accident, we don't know. He had a shoulder dislocation. What we have dislocated, we don't know. So it may compress, usually shoulder dislocation compresses the cord level rather than the trunk. Sometimes trunk or a pan plexus can be affected by the stretch, but usually affected site of compression is at the cord level. Now the question now is, so I know what I'm trying to say is that this can explain the sparing of the supra-infraspinatus and deltoid and triceps by the radial nerve just above the elbow. You can't explain.
But are those muscles really spared? Supra-infraspinatus really spared, or are they affected?
No, they are not. They are not totally spared. They're, in fact, supra-infraspinatus is a relatively good power. Deltoid is also got 2 to 3 power.
So that means they are also involved. So we can't.
They are also involved. Yeah, they are also involved. No, they are also involved. But the management aspect is that if it is even got 2 power, they got a good chance of recovery subsequently. That means the nerve supply is still intact.
But it's already 8 months, no? Still 8 months. After 8 months, also there's a chance of recovery.
Yeah. It will go on recovering. Once it started recovering, it can recover if the lesion is proximal. But if you're not recovered even after 3 months, muscle has not been separated by that, then unlikely to be recovered. That depends upon the length of the distance between the site of injury and the muscle. For example, if it's a distal muscle weakness is there, suppose you have got injury to the, say, medial cord, it will take nearly 1 year for the distal muscle to get the power. But the proximal muscle separated by the medial cord will will recover first because of the regeneration is taking place. So that's why in sciatic nerve palsy and due to the injections or whatever trauma, hip dislocation, I have seen patient improving after 1 year. The dose of extreme weakness syndrome. But the proximal muscle is up and recover fast. Even after 3 months, the proximal muscle is not getting re-innervated. It is you have to go and submit the patient for surgery. That is why you have to advise the surgeon which you are to operate in this particular patient. Let us see. Now, what do you want to do now? You have to confirm, no? Your
Nerve conduction.
Nerve context. Let us see the nerve context. No potential from the median, no potential from the ulnar, no potential from the radial. Axillary is picked up 1.8 microvolt. Is picked up from the right axillary. Musculocutaneous, no response. But look at the suprascapular normal amplitude. Okay, that's a normal amplitude. So what does this tell you? This electrophysiological abnormality.
The proximals are improving.
Yeah, the proximals are improving. Not all. I'll come to that. Not all. The separate by which cord is more important. Now, this shows the upper trunk is not affected. The upper trunk is not affected, we are certain, because that has started improving. Suprascapular nerve is good power. Deltoid is picking up. The middle trunk, medial lower trunk may be affected here. Now, can the lesion be at the cord level with electrophysiologically? Here, all cords may be affected with partial effect of the posterior cord. Why? Because the deltoid has got not a normal amplitude, only a small amplitude. But probably the posterior cord lesion, the muscle supply the posterior cord has started improving. That is when the deltoid has started picking up. The CMF amplitude from the deltoid is low, so posterior cord might have been affected, obviously affected. Now, this is a sensory in this patient, no potentials. Medial antebrachial, lateral antebrachial, everything is absent. FA is also absent because FA is done only by these two nerves. Now we have localized to the cord level. What will you advise the surgeon now? Which cord you will try to, which part the surgeon has to interfere?
No, Madhu, this
Medial cord.
absence of
Subhash, please.
Madhu, absence of the sensory potentials, doesn't that mean that the lesion is distal to the ganglion?
Yeah, obviously, distal to the ganglion. It's not at root level at the proximal to the ganglion, not a root radicular.
We can do contrast, sir, to localize further.
No, it is 8 months now. The contrast scan is not going to help you. Even if you have some confusion, that's not. What is more important is that even if there is lesion there, is the lesion likely to improve or not? That is a question by the orthopedist. You have to give an answer to him whether you go for surgery, not go for surgery.
EMG.
EMG can be done to locally, that we can do. So to explore all the cords, will you ask the patient to explore all the cords to explore?
Medial cord.
Correct. Or only in medial lateral cord. So let us see the EMG in this patient. EMG is another important clue for the same surgery. The EMG potential I picked up, now you know that muscle is getting re-innervated. Well, let us say the EMG one by one. This is the deltoid.
Okay. കൈ ഇങ്ങോട്ട് തള്ള, വെളിയിലോട്ട് തള്ള, വെളിയിലോട്ട്.
Put potential from the deltoid. That means you don't tackle go ahead and do anything with the posterior cord because deltoid is getting re-innervated. Let us go to the other muscles. Covering the biceps. No activity, no potential. Muscle to move. No potential. Remember the brachioradialis. Again, no spontaneous activity. And no potential picked up by ask the patient.
ഇങ്ങോട്ട് പൊക്കാൻ നോക്കിയിട്ട്, അതായത് ഇങ്ങനെ പിടിച്ച് നിർത്താൻ നോക്കിയിട്ട്.
Okay. I'll show the fact that the biceps is not picking up any potential. There's a proximal muscle. Even after 8 months, that means that muscle is not getting re-innervated. So we have to tackle the reassert the lateral cord. Because the lateral cord is supplying the biceps, other forearm muscles, or they're supplied by the median, not supplied by the lateral cord. So that become weak. So for a minute, about a minute per second, when carpi radialis and ponitis are all separated by the lateral cord of the lateral cord. Then and is no potential picked up on the brachioradialis also. That means his radial part is affected partially, but we don't know because that we are localizing to the posterior cord or to the radial nerve. The posterior cord lesion is causing the weakness, which logically so because injuries in the brachial plexus. The brachioradials may get innervated later on, even the potentials are not picked up because the lesion, the regeneration might not reach up to the brachioradials.
Ready?
The place.
കൈക്ക് നോക്കാൻ നോക്കിയിട്ട് ഇങ്ങനെ വെളിയിലോട്ട് തള്ളിയിട്ട് മറ്റേ
Not as good as the right.
തള്ളിക്ക okay.
No potentials.
That's which muscle?
Again, what basic potential picture. See, what's the carpi ulnaris? Okay, now what we understand is that the muscles separated by the medial cord, the proximal muscles from the medial cord, like for example, the flexor carpi ulnaris is picking up potential, but not from the FDI. FDI only one potential is picked up. So that means it's going to get re-innervated slowly. So the medial cord may not be affected totally. What is totally affected is the lateral cord, because in the biceps and the proximal muscles of the lateral cord is not picking up. And we expect the other muscles also to be involved, not involved. Biceps is not picked up naturally, it must also be not be picking up. So what will that do, surgeon now?
Correct the lateral cord.
Invariably, you have to go for the lateral cord. That is not going to recover unless you intervene. But there's a good chance of recovery for the posterior cord and medial cord. Even though the medial cord almost 0 for we got. But the physiology, some activities are picked up from the vesicular arteries and the LTA.
But Madhu, what is the surgeon going to do anyway? I mean, even if you give him this information, what will he do?
What they re-explore and find out when neuroma is there obstructing it, or they can, there is nothing there, they feel that whatever surrounding them, cut the small segment and research it. Sometimes some tissue may get interposed in between that, what do you call it? Yeah.
Transposition. Transposition. Nerve transposition.
Yeah, not transposition. So that's but this very often, haven't you had cases referred to you by the orthopedics and for such similar problems? I get often referral like this to advise him whether to intervene or not.
Yeah, it was a very good case, sir. Very.
Yeah.
Sir, I have one doubt, sir.
Yeah, please.
Sir, you told us C5, C6, if the root is involved, then it is mandatory that the deltoid should involve more than the biceps.
It's not like that. Both are separate, the C5, C6, but the deltoid, invariable deltoid is more weak, it will become more weak than the biceps.
Okay, sir.
Sir, I've seen certain patients with so-called brachial, the neurologic amyotrophy,
Yeah,
with the deltoid and biceps weakness. So in those cases, how to differentiate whether it's from the root or from the part of the plexitis?
No, if a person has got deltoid and biceps weakness, it can be at the root level or at the upper trunk level. But the root level, you take it weakness of the serratus anterior because and the rhomboids. There you have to carefully look for the involvement of the rhomboids and serratus anterior. This is the two muscles which go and differentiate between a root level lesion from the upper trunk lesion. In our case, that is not required because already we know that deltoid is failed. Then we know that lesion is not at the upper trunk or nor the C5, C6 root.
What happened to this patient, sir? Was the surgery done?
Yeah, this is referred to surgery. This patient came to me 4 days back.
Was the surgery done?
No, he referred to him for surgery. He came to me only 4 days back.
Okay.
I saw him 4 days back. So he asked me to do surgery. I said, go ahead and do the lateral cord. And the window just explore the middle cord also. If there is anything preventing adhesion surgery, you can remove that also. But don't touch the posterior cord, it's going to improve. That much we can advise the surgeon.
Sir, my question is how to differentiate a C5 root from an upper trunk of the brachial plexus. Like if the patient has got weakness of the deltoid as well as biceps.
Yeah, the same thing point I said, no?
The serratus and in the rhomboids.
Okay. Yeah. They'll be spared in upper trunk lesion.
Okay. All right. Okay.
But this is applicable, whatever this partial affection are more common with conditions like neurologic amyotrophy, where only some muscle may be affected, some muscle may not be affected. But in a cut injury, you can't explain one muscle to be 0 to be affected, one muscle to be affected with a gait 0 power, other muscle having a grade 4 power, grade 3 power. There is unlikely for a cut injury or a trauma. But the other is a demyelination, which sometimes pick up certain nerve vesicles of a nerve. There can be a vesicular vulnerability. That is sometimes neurologic amyotrophy produce only flexor pollicis longus weakness. All other muscles are spared, or only phrenic nerve involvement. So such things are occurring in neurologic amyotrophy.
Sir, in that case, can we go ahead and do a EMG of the serratus or the rhomboids just to differentiate from a root in lesion?
Yeah, of course. EMG is an extension of the clinical examination. Where we can, if you suspect a replicatory involvement, definitely you can do the EMG. Here we are, we say must because we want to know the recovery, the nascent potentials. You can see the nascent polyphasic small potentials in the ulnar the FCU as well as in the FDA. That means the potentials are coming back slowly.
So how will we localize lesion at the level of division? Because here there is a clavicular fracture. The most likely site is one is division.
Yeah, correct. Order of the division. You're right. The divisions are just behind that. No, very difficult to define. It depends upon which division is affected. For example, the posterior divisions of all contribute to the posterior cord. So it will mimic that of the posterior cord. If the anterior division of the C5 will be affected, it will be similar to that of the lateral cord, depending on which division is affected. Suppose it is the anterior division of the C5 root is upper trunk is affected. That muscle separated by that ventral division going to that C5 root going through the lateral cord will be affected. For example, you get weakness of the biceps.
Okay, sir.
Now, the simple thing to remember in brachial plexus lesion is that the distribution of muscle weakness is similar to that of the root, is same for the root and the trunk. Root and the trunk, because the root forms the trunk. So it is similar, except that the muscles coming directly from the roots are affected in the radical root involvement, but not in the trunk. On the other hand, the distribution of muscle weakness in a cord lesion mimics that of the multiple nerves which arise from the cord. It will not conform to the root distribution. Once the cord is reached, it favors multiple nerve pattern, not a root pattern or a segmental pattern. The division involvement is extremely uncommon because it's a short segment is there. Invariably, when the division is affected, the cord or the trunk also implicated.
Okay, sir.
Sir, it's 8 months since the injury, sir, but the biceps is not showing any potential. So what are the chances of improving after the surgery, sir?
No, that I don't know. But I think some of them have improved remarkably even after years. It's only the nerve is not prevented from growing, no? They are allowing a chance to recover. I don't know how much that question I'm not very certain. How far you will improve.
So further extension of the question, sir. For if a patient comes after 3 months after plexus injury, should we proceed for the surgery option?
No, you have to find out. Now it all depends upon the time taken for the regeneration to occur. It is said to be 1 millimeter per day, slow growth. And that's on his cut. So roughly you can calculate what is the distance between the injury and the muscle you are doing the electrophysiological test. For example, it may take at least 3 to 4 months for the nerve to reach the distal part, even more than that. So that there is a time you allow for the regeneration to occur. But the criteria for 3 months is that because if there is a muscle is supposed here in this patient biceps is affected, and obviously 3 months is sufficient time for the muscle to biceps get reinnervated. So even after 3 months, the biceps is not get reinnervated means that that muscle is not going to get reinnervated. There's no point in waiting. Now, even if you don't get a potential from the abductor digitorum minimi or whatever it is, the distal muscle, you can still wait. The muscle may improve because 3 months is not enough for the nerve to reach the abductor digitorum minimi or whichever distal muscle you're thinking about it. So to find out that muscle will be, whether we are not sure, no, at that point of time, we cannot wait. Because if we go on waiting, the muscle will be wasted, and if we do the surgery late, it will not have any benefit. To find out whether the muscle is getting renovated or not, you have to do EMG of the separate by that particular nerve from proximal to distal. Suppose you are not getting the distal, go to proximal muscle supported by the same nerve. Again, proximal. If that muscle is picking up, that means nerve is started regrowing. So you can wait.
So I got one.
You understood, I think, what is it? Well, depends.
Yes, sir, but what the surgeon will do if the posterior lateral cord is severely affected in this patient, sir?
Yeah, severely affected.
Then what the surgeon will do in these patients if they explore the lateral cord?
They explore the lateral cord. They can, if they find if there's something obstructing the regrowth, as Bindu was telling, nerve reposition they do. Usually
the nerve position is usually done in the nerves or in the roots also, sir, because it's usually in the nerves now, sir.
I usually in the nerves. I do not know much about that. But brachial procedure surgery is done. That I'm very sure. People do brachial procedure surgery.
So one doubt. So can we, with this EEG, this EMG and the nerve control study findings, can we definitely roll out a post-traumatic neurologic amyotrophy?
No, it is, I think, very unlikely. This is a trauma and dislocation. That's so when you talk simultaneously, it's likely to be that only.
Post-traumatic brachial neuritis also.
Yeah, but it is immediately occurring that just following the trauma. I think critically possible, but logically it's related to the trauma. And you got so many problems. The brachial arteries also got confused. That's a severity of trauma. Okay. Shall we go to the next case now?
Yes,
Yes,
sir.
sir. Yes, sir.
Yes, sir. Yes, sir.
This case is referred to me by Dr. Lenny Thomas Matthew. From Kothattukulam, the CAT C is grateful to him for referring this case. This is story of a 32-year-old lady. She developed COVID infection 2 months back. 1 week later, she was tested negative. 2 days after, patient developed paresthesia of both legs up to the ankle, which spread to the lower 1/3 of the legs over the next day. On the same day, she also noticed paresthesia of both hands, as well as for the upper front teeth and gums. She was telling it is not in the lips, but in the upper 4 teeth and gums. No paresthesia and numbness over the upper and lower lips. She also gave history of electrical paresthesia in both upper limbs and anterior chest on flexing the neck. Next day, patient developed heaviness and tightness of both legs and difficulty in walking in the form of unsteadiness, requiring the support of one person to walk about. No weakness of upper limbs or any dysarthria or any dyspnea. She was admitted to the local hospital and was given injection for 5 days, that is IV methotrexate, which she started to walk without support after 3 days of completing the injection. However, the numbness of both hands and gums improved. After the initial improvement, which persisted only for 3 days, her imbalance was walking worsened again requiring support from one person. And since then, the disability is persisting as such, and then that is for a second. So I'll tell the story once again. First, she developed foot infection, developed numbers of both lower limb up to the ankle, and then something like limb sign in upper limbs, compared to the upper limbs. Then numbness of the upper teeth, not and gum, not in the lips. Next day, stiffness and tightness and difficulty in walking, and unsteadiness of gait requiring support of one person. And following injection, she improved, but again after 3 days, the difficulty in walking worsened. That's the story. Well, I'm not going to give the history of the patient. The point what it means.
ഈ കൈക്ക് മരപ്പുണ്ട് അന്ന് തന്നെയാണ് മരിച്ച ഭാഗത്ത്
ഇവിടെ ഇങ്ങനെ ഈ ഭാഗം മൊത്തം മരപ്പായിരുന്നു.
ചുണ്ടിന്റെ
Not lip,
ചുണ്ടിനല്ല മോണ
but
താഴത്തെ ചുണ്ടിനോ താഴത്ത് കഴിഞ്ഞ് പിന്നെ ഇഞ്ചക്ഷൻ എടുത്ത ശേഷം നമുക്ക് എത്ര കുറഞ്ഞു?
okay. Then this part of the story also you can please.
വൈബ്രേഷൻ
ഇവിടുന്ന് ഇങ്ങോട്ട് കണ്ടിരിക്കും
ഇവിടെ
ഇപ്പോഴും ഇപ്പോഴും വന്നു
ഇവിടെ ഇങ്ങോട്ട് ഇവിടെ
അത് കഴുത്ത് അനക്കുമ്പോഴാണ്
കഴുത്ത് കുമ്പിടുമ്പോ
കയ്യിലോട്ടും നെഞ്ചിലോട്ടും കാലിലോട്ടില്ല.
The second day. Okay. Now I'll show the video of the patient. Trainers are normal.
ഇവിടെ നോക്കുമ്പോൾ ഇവിടെ ഉള്ള താഴെ കണ്ണ് മുറുക്കി അടച്ച് മതി. ഒരു മിനിറ്റ് പല്ല് കാണിച്ച ഈ നാക്ക് നീട്ട് ആന്ന് പറഞ്ഞ് ആ ഇത് വലിയ പല്ല് അറിയാമല്ലോ.
So the face is normal.
ഇതൊക്കെ അറിയാമല്ലോ. കൊടുക്കില്ലേ മുറുക്കി പിടിച്ച
Bone power normal.
കട്ടിങ്ങിനകത്ത് പിടിച്ച്
Opposite power normal.
വിട്ട് എൻ്റെ വിരലി തൊട്ട് മൂക്കിത്തുണ്ട് അങ്ങനെ ചെയ്ത് മറ്റേ ഗെയിം ചെയ്ത്
No incontinence in the upper lip. Lower limbs passive, both lower limb.
അങ്ങനെ കൊടുക്കണ്ട മോളെ.
Power over.
വിട്ടോ വിട്ടോ ഇത് പൊക്കി പിടിച്ചേ വിട്ടോ ഇത് വടിവ് പോലെ പിടിച്ച സ്ട്രെയിറ്റ് ആയിട്ട് വിട്ടോ ഇത് പൊക്കി പിടിച്ചേ വിട്ടോ മുള്ളോട്ട് പിടിക്കണം വിടരുത് ആ ഇത് പിടിച്ചോ ചവിട്ട് എൻ്റെ കയ്യിൽ ആഞ്ഞ് ചവിട്ട് മതി വിട്ടോ ഇത് തള്ളവരിൽ പൊങ്ങി നിൽക്കണം അല്ല സമ്മതിക്കരുത് പിടിച്ചോ അത് തന്നെ ഇതും പിടിച്ചോ മതി വിട്ടോ ഇനി ബലം പിടുത്തൊന്നുമില്ല തുറക്കും അത്രയും വേണ്ട പതി തുറന്നേ തുറക്കും ആ
This is normal. Can perfectly distance. Abdomen refers for absent. Lower refers for saturation.
കൊടുക്കില്ലേ
Angled cervix.
ആ നീട്ടി വെച്ചു
And as for inside. All throughout the body, both upper and lower.
ശരി
Difference
ഈ കുത്തുന്നതും വ്യത്യാസമുണ്ട്
between the upper and lower.
ശരി ആ വേദന കൂടുമ്പോൾ നോർമലായിട്ട് അറിയുമ്പോൾ പറയണേ
Yes.
ഇവിടെയൊക്കെ ഇപ്പൊ നോർമലാണ് ഇവിടെയൊക്കെ നോർമൽ
Lingual region 60.
നീ കൂടുമ്പോൾ പറയണം കൂടിയ ഓടം പറയണം നോർമലാണ്
Here is telling you.
ഒരു വൈബ്രേഷൻ ഇതോ
Both in upper and lower limb.
ഇതോ നോക്കിക്കോ ഇപ്പോൾ ഉണ്ടോ ഇപ്പം ഇപ്പോഴേ ഇപ്പം
Telling yes.
ഇപ്പോഴോ ഉണ്ട് ഇപ്പോഴോ ശരി
Now, since the upper limbs are normal,
ഇപ്പോഴേ ഇപ്പോഴേ ഇപ്പോഴോ ഇപ്പോഴേ 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 ഇപ്പോഴോ
nose is not able to see.
അറിഞ്ഞൂടെന്ന് പറഞ്ഞാലും മതി ഇപ്പോഴോ അറിഞ്ഞൂടെന്ന് പറഞ്ഞാലും മതി അറിയത്തില്ല
You
ഇപ്പോഴോ
can't feel.
തോന്നണോ ഷുവർ അല്ല ഇപ്പോഴോ ഇപ്പോഴോ
You cannot able to.
ഇവിടെ തൊട്ട് മൂക്കെത്തണം തൊട്ടെ
There's
മൂക്കെത്തട്ടെ
no information about it.
ഇത് ഇനി അതുപോലെ ഈ കൈ ഉണ്ട് ഇത് മറ്റേ കൈ
Okay, so summarizing the finding, and this is the gait to the patient. I'll show the gait. He cannot stand, feet closed, eyes open, or down. Tremendous attacks here. He is tending to fall forward, like so. Even at this position, is not steady able to hold her. Once he closes, also this plastic. Some protection more in the face. Okay, but it goes. So on examination, Taylors were normal, motor upper limb tone power normal, lower limbs bilateral spasticity, power normal in all muscles in the lower limb, ETR Georgiak normal, upper limbs normal, lower limb both knee and ankle checks were brisk, abdominal reflex absent, plantar indefinite, sensory touch normal in both upper and lower limb, impaired pain up to the internal region bilaterally, vibration normal and normal in the upper and lower limb, DP normal in the upper limb, impaired over the toes. Stands, patient can stand only on a wide base, thrombus positive, tandem walking is not possible.
Upper cervical cord.
Upper cervical cord, agreed. Any other possibility you would want to say?
Brainstem involvement, sir, because severe ataxia is there. Upper limbs, in spite of normal vibration
No,
JPS.
there is no coordination upper limb, lower limb.
Upper limb mild unsteadiness is there, no, sir, in the distal while she's pointing the fingers.
But no, I think we can take it normal. That mild degree can. So look at the degree of attacks that the patient had in the lower limb. But to that,
Madhu,
yeah.
Madhu, what were the tendon jerks, reflexes?
Tendon jerks, upper limbs are slightly brisk, but rapidly brisk in the lower.
Lower limb is brisk.
Yeah, brisk. Exaggeration.
Yeah, in the history there was something in the gums also. What was the complaint in the gums?
Exactly, that's the point. If the patient was combining of paresthesia, just like numbness of the hands, numbness of the upper four teeth. That is upper. Yeah, on the gum also, but not on the lips. But,
cervical cord lesion with balaclava helmet type of sensory loss.
But in that case, it should have been affected the posterior part of the head region, no? Not near the gum. Gum area will be anterior part of the mouth will be the last area to be affected in upper cervical cord. Assets up only to get involved.
Okay. Fontaine demyelination, sir. Fonts.
So you want to think of Fontaine lesion?
Yes, sir.
Okay.
Both cervical and pons, sir.
Cervical and Fontaine lesion.
Because Lermitsen is very prominent. So I attribute to both the posterior column and the pyramidal tract in the cervical cord and possibly spinal tract of trigeminal in the pons.
Okay. So that's we can't describe by a single site, I think. Even, do you think it's a cervical cord is likely involved because the Lermitz phenomena, but look at the other signs. She has no spasticity in the upper limb, no incoordination in the upper limb, and the lower limb is severely, she can't even stand.
So she has the pyramidal signs also there in the lower limbs.
Yeah, pyramidal there in the lower limb, not in the upper.
So possibly she has multiple sites like multiple sites of demyelination. One in the dorsal cord, other in the pons, and
my question is, which structures are affected in this patient?
Posterior column, that is corticospinal tract in the cervical cord, and descending tract of spinal in the bones.
Endothalamic trigeminal.
Why do you want to think of endothalamic type? Because the middle part, you can't say the crossing fibers from the upper part of the spinal nucleus.
Vena cerebellar.
Okay. Okay, that's a good. That's a good answer. Now I'll tell you what. I'll come to that. I'll come to the discussion one by one. So what do you want now?
MRI.
MRI of the brain as well as the spinal cord.
Both brain and spinal cord. So this now my question is I wanted to know what is causing an imbalance. Is it posterior column involvement?
No.
Yes, it is posterior column.
Okay. But what is
It can be posterior column as well as the lemniscus, both.
Both, sir.
posterior column and lemniscus means I didn't understand. By lemniscus means what?
Sir,
More than posterior column.
Posterior column. Posterior column.
More than posterior column, because when you're sometimes when you're doing the rhombus test, it was not really that posterior to cause so much of attacks.
Yeah, he has got only JPS impairment in the toes, and vibration is normal in the toes.
In addition, there is maybe involvement of vermis also, sir. Connection.
Okay, which vermis?
Rostral vermis.
Okay, let us see. Let's come. So it's a posterior column effect. It's cerebral. It's a cerebral lesion. It's very serious. This is the problem. No, it's not very simple, straightforward thing to easily think. Just you find JPS loss, attacks is out of proportion. Just got a Lermite sign, but nothing in the upper limb. Just got some funny sensory loss in the upper gum without any dysarthria, any other finding. So let us see the investigations. I'll come to the discussion later on. This is the MRI brought by the patient. MRI cervical cord. MRI dorsal cord. Lumbar cord. Okay, this is the MRI of the spinal cord. Then the MRI of the brain. This is a diffusion weighted sequence from the below upward, upper cervical cord, pons, midbrain, upper midbrain, subcortical white matter. Then this is the flyer sequence. If anyone want me to go a little more slow, you ask me, please. I can go slowly. This is a flyer sequence. Okay. They are normal.
What about cervical cord?
Cervical cord is this one.
Normal.
Is midbrain normal, sir? In flare.
The flare I'll show you. This is the flare midbrain. Yeah.
In this right side cuts.
Yeah, it's normal only.
What about periaqueductal? Is there a brightness there?
Yeah, this one.
Yes, sir.
Yeah, see, adjoining that, I don't know it's really abnormal or not.
Artifact.
Maybe
What about cervical cord? Cervical cord was normal?
Pardon?
Cervical cord was normal, huh?
This is the film they brought, this is normal.
Did you repeat one MRI?
Okay, we want to repeat MRI. Before that, they did a conduction study because of that. The cell came the conduction study also. I'll show that. That's also normal because nothing in the MRI is seen to account for the ataxia. So the NCV was done. That's also normal.
We will repeat one MRI.
You want MRI?
One more MRI.
Repeat MRI with smaller cuts.
Repeat MRI.
With contrast, sir.
Okay, where? Which part you want?
Cervical.
Brain stems.
The brain stem and cervical
I
cord.
want a brainstem as well as the cord, sir. Probably in the cervical and dorsal.
Now, before that, I want to know which area you want to look for. So you can ask for a thin cut, I'll give you, but you can not ask for a thin cut of entire brain and entire this thing. You have to concentrate.
For cervical cord.
Medullary junction.
Okay.
So we have to take in consider the symptoms of the teeth, upper teeth.
Pons, sir. Pontine.
Okay, points that you have to take. Good. So before that, I want to analyze one thing. Let's analyze what is causing her walking difficulty, because this will depend upon what area to look for. Otherwise, because what often happens is that you have to instruct the radiologist. You have to look here, this particular type, take thin cut. You have to, whatever techniques you do, I want that structure to be delineated. That instruction you have to give to the radiologist. Otherwise, he will take an MRI and then send you, just like you send for in a private scan center, you send an MRI. It will not do any use. But you have to instruct the radiologist. So is it sensory ataxia? Is the first question. Is it cerebellar ataxia? Unlikely with the posterior column, since only sensory abnormality was embedded JPS of the toes. JPS loss was, if you remember, the JPS loss is confined to the toes, it will not cause sensory ataxia. You must have any number of diabetic patient with embedded total loss of JPS loss in the toes. They are not ataxic. It will not cause such severe imbalance when the patient cannot walk even. See the way she's standing with wide base. The moment she, and of course it's aggravated by, the moment she closes, she falls forward. So posterior rhombogism is there. Posterior rhombogism is not only seen in posterior column. I'll come to that later. Then is it cerebellar? So, yeah. If it is cerebellum, which part of the cerebellum is affected?
Vermis.
Which vermis?
Inferior vermis.
It should be in the anterior lobe, not in the inferior vermis. If it is inferior vermis, okay, what you said is correct. Inferior vermilation can produce gait ataxia only, correct. But what you said is correct. So if it's only gait problem without any nystagmus or upper limb incoordination, pure gait ataxia can be seen in either flocculonodular lobe lesion and anterior lobe disconnections. But what is likely in our patient? It is
Connection, sir.
No, is it in the inferior vermis or the flocculonodular lesion or in the anterior lobe?
Anterior.
Anterior lobe or its connections. So its connections can be involved with the anterior lobe. So
okay. Why not flocculonodular lobe?
Because why?
Upper limbs are
no ocular semblance, sir. No.
Ocular, that's the point. So upper limb will be normal in flocculonodular lobe as well as an anterior lobe. But flocculonodular lobe likely to produce eye signs. Okay, either in the form of a casebook nystagmus, other various nystagmus can occur in flocculonodular lobe. So it's likely to be in the anterior lobe, or is it a functional gait that can be astasia abasia?
Could be, sir.
Unlikely.
Why unlikely?
Disabled.
Because the gait is wide based as well as there is a dragging on both sides.
Let's put some other organic findings, like spasticity is there, biscuitous is there. So it's not, doesn't look like an astasia abasia. So now my question is, for argument's sake, suppose this patient did not have any spasticity in the lower limb. Okay, then how to differentiate these two, anterior lobe versus astasia? Clinically.
Upper limb involvement.
Tandem gait, sir.
And the gait.
No, gait will be abnormal in both. Astasia abasia gait will be fine, will be walking ataxia like that.
What about heel sheet incoordination?
That's the thing you have to look for. I'll tell you, because yes, this is the point we already said. Now you have to look for lower limb incoordination. In flocculonodular lobe lesions, you will not have any lower limb incoordination. Lower limb will be present in anterior lobe lesions. We see also lower limb incoordination will not be there. Only the limb will be abnormal. So look at the lower limb.
പിന്നെ എടുത്ത് ഉറച്ചുകൊണ്ട് വരണം
Severe lower limb incoordination.
അല്ലേ കറക്റ്റ് എല്ലിൻ്റെ പുറത്തുകൂടെ വരണേ. ഒന്നൊരു ശ്രമിക്കും, ഒന്നൊരു ചെയ്യും. താഴെ മുട്ടിക്ക് ഇനി അവിടെ കൊണ്ടുപോയിക്ക് ചെയ്ത് ഒന്നൊരു പൊക്കി ഇവിടെ വയ്ക്കും. ഇങ്ങനെ പൊട്ടിച്ച് ഇങ്ങനെ വരണം, പൊക്കിയിട്ട് താഴെ മുട്ടിക്ക് താഴെ മുട്ടിച്ച്.
But Madhu, I have a point.
Yeah.
If it is a because of the flocculonodular lobe or a Vermean ataxia, then will the limbs show incoordination because this is limb ataxia, whereas those are gait ataxia. Will it still be abnormal?
Yeah, the point is that, as you said correctly, if it is a flocculonodular lobe lesion, they will not have any limb incoordination.
Yeah.
Only eye sense will be the normal. Only problem, that's only a postural equilibrium problem. So they will not be able to stand or walk. They can even truncal ataxia, but there will not be any limb ataxia, as you said correctly. But if there is due to anterior lobe involvement, where the spinocerebellar tracts end from the lower limb, you get lower limb incoordination as well as gait ataxia. So that presence or absence of lower limb incoordination help to differentiate whether the lesion is anterior lobe of the cerebellum or the flocculonodular lobe. In the case of superior cerebellar tract lesions, you get upper limb incoordination and trunk tension. So this patient has got lower limb incoordination, so likely to be absence of eye signs, so likely to be anterior lobe response. Okay. But the MRI is normal now in this patient. So you want to look at repeat MRI, no? So the repeat MRI. This is the repeat MRI. So look at the picture very closely now. This is where you get the help of a good radio.
It's a flare contrast.
This is the flare. I'll show one. I have a lot of films. I'll show you 1 second. Hyperintensity in the hyperintensity in the region of the internal capsule where the corticospinal tract is situated. So hyperintensity in the corticospinal tract. This also can be seen in the crus cerebri where the pyramidal tract is situated. Anterior part of the and this is the again superior cerebellar epidendral that is affected. And anterior part of the middle. So the pyramidal tract is affected one throughout the entire length of the from the corona radiata and also the superior cerebellar epidendral. And let us show a lot of films. I'll show one by one. It shows the hyperintensity in both pyramidal tracts, corona radiata, crus cerebri and pons, and pyramid of the medulla, and hyperintensity in the superior cerebellar epidendral. This is a gradient which is normal and just let's see the contrast film now. The contrast enhancement was seen in the superior cerebellar epidendral. Did you see that?
Okay.
That is showing the hyperintensity. So another picture more clearly. Thin cut post contrast.
What is that thing?
It's only the vein which is seen. In fact, sound you are hearing is from the radiologist. Now this is the thin cut post contrast. See the contrast, how beautifully you can see the enhancement there. Except superior cerebellar epidendral. Yes. Then you can see the sagittal cutting. Nothing in this advantage of the cerebral.
No, second. Okay. Right. Scientists were right. Tax is all.
Enhance for super epidemic. So, what do you think now?
Demyelination.
Heliodosis?
No, the question now I come to the etiology before before coming to the etiology, I would like to know the sites of lesion. So question now is, yes, we can explain the spasticity in the lower limb because yes, patient got density along the pyramidal tract. Why it is affecting the lower limb comes odd, but still you can explain that. But there is no lesion seen to account for the ataxia. Taking the anterior lobe and this, but instead we find a hyperdensity in the superior submular peduncle, lesion of the retention tremor or upper limb incoordination, which is not visible. Now,
Sir, if spinocerebellar cerebellar tracts are involved, then
exactly, good, very good. So you can explain cerebral signs, but upper limb lumbar muscles are not pyramidal lesion. And this cause attacks no SCP infection classically cause upper limb incoordination infection. So we did MRI of the cervical spine. Also, spine even in this cut you can make out hyperintensity coming from the cervical cord down like long. The axial, the core concentrate on the axial cut on the right side. Part of the middle. Cervical cord hyperintensity can be seen on both sides, the lateral pedicles. Yes, right. So some other picture also. So here you can see both sides, the lateral part of the pedicles. Again, you can find out exactly. And also the posterior column little bit. Yes, but conveyed joint cells. Mainly in the lateral pedicles. Bringing down, yes, but hypertension in the posterior column also. See, there's posterior column hypertension. Especially the gray cell is stacked. There is more prominent pyramidal involvement in lateral pedicles on the right side. Can you make out that? Then come to the thoracic cord now. The thoracic cord also there is hyperintensity in the lateral part. But nothing in the lumbar cord or the cord. The lateral pedicles and posterior column cervical thoracic cord. Again, I will show one more two, three things I will show. The upper part of the coming down, it can find out. Anterior part, it is following the track in the bottom. Then going straight to the periphery, the lateral part. Bring up the affection might have been responsible for the numbness of the upper gums. Because it keeps contain lesions. Now this is the conus of spinal cord. The conus attends to the column and the lateral pedicule, mainly the right side. Periphery the cord is affected. See, there is the extreme peripheral part of the thoracic part is also affected. That's the region of spinal cerebral.
Okay, that's also there.
It is find out the periphery of the body. Simple. This is the another common characteristic of thin cut. This is the wine glass appearance of the corticospinal dependency in the 3D player. This again, you can find hyperintensity is concentrated with the lateral part of the spinal cord and not on the central part. Again, you can find out here. So this is the understand the for lateral part. So is it posterior column or the or spinal cerebral tract lateral column? More likely it's lateral tract severe because the base severe rhomboid with only mild JPS loss in the toes and normal vibration. Now, that side this patient is likely to be in the anterior cerebellum or its connections. So the anterior lobe is normal in the MRI, more likely the spinocerebellar tracts are affected. You can explain the posterior column, but the posterior column loss is very minimal in this patient.
And questions.
And a skin coordination is there in the lower limb, which cannot be explained. It's just loss of vibration alone. No, loss of gateways in the toes alone. So most likely spinocerebellar tracts, as you can see by the hyperlateral. And rhomboidism can also occur with the lesions of the cerebral tract, not only with. Now, this is the differentiating points between the rostral lobe and caudal posterior cord. This for condition safe. Anterior lobe is gait ataxia. The caudal vermis, that is polopranodal lobe, can produce gait and truncal ataxia. Fusion normal in vermis, normal vermis. Rhombox is positive in rostral vermis, is negative in caudal vermis. No titubation, that's a different point. This is between vermis and hemisphere. There is here is output of the cerebral tract movement. So they put these abnormalities like like say etc. This is from the test book. Cervical definition.
But Madhu, that when you are talking of anterior lobe,
yeah.
Because anterior lobe will involve vermis as well as paravermian areas.
Yes, exactly. You are perfectly right.
So if you take vermis alone in the anterior lobe, then it should not cause this. It is lateral paravermian areas which you are talking about.
That is what I said. You are perfectly right.
Madhu, what was the etiology in this patient, sir?
And etiology most likely post-COVID. So I put the patient media prednisone by injection. Sorry, not media prednisone, rituximab. She has already received media prednisone. So I put her on rituximab and sent the patient. I don't know the follow-up because I discharged the patient only 2 days back.
Very great case. Must be post-COVID only. Otherwise,
post-COVID Adam is my likely diagnosis. And the further investigations, CSF was normal. Anti-NMO and anti-MOG antibodies were also negative. The other DD was NMO spectrum disorder, but these were negative in this patient.
So even in the first MRI, the pyramidal tract appeared hyperintense. Prospectively, the first MRI itself, the pyramidal tract, especially in the internal capsule area, appeared hyperintense.
We go to that. I want not very much confused. So let me see that. Give 1 second.
Internal capsule level, sir.
I'll come to that. So difficult to comment on that in that hyperintense, not hyperintense. This is the internal capsule.
Sir, next cut, sir. Yeah, sir. In the posterior limb.
Yeah.
Yeah, sir.
Retrospectively thinking, if you ask me to be there is some hyperdensity like here, there.
Yes, sir. Retrospectively only.
If you see like just like this, the first film, difficult to comment on that, and that only to one side.
Yes, sir. Yes.
Facial bilateral spasticity, so it will be difficult to comment on that.
Right.
In English,
So
there's
subcortical white matter also is there in flares.
Yeah, it's all come, and the radiology put this also normal.
No, Madhu, in English, there's a saying, hindsight is the best sight. But what I found fascinating is this gum involvement, because, this gum involvement and tongue involvement, this can be, these can really, sometimes they give clue and sometimes they can be very difficult to analyze. I had recently one patient, she only complaint was tongue numbness, that is all. She said, why? And after that she left me, and I came to know from somebody else that eventually she had developed GB syndrome. So,
yeah.
So that's why I was fascinated by this, what is this gum happening? And there was an explanation for that.
Yeah, that's nice.
I mean, if she would have come to you only with gum numbness, probably you might have sent her away.
Absolutely. Not as functional, or if it's a short duration, use a viral vitamin and follow up.
No, if she had come to you only with gum, probably you would have sent her to a dentist.
Exactly.
And then she would have gone to other neurologists after a few days. But fascinating case, Madhu. Fascinating. Thank you so much. Only you can see and analyze these, and only you can do their MRI with the help of your son-in-law.
Yeah, that's the problem. That's the thing, no? So once you suspect, no, they say persistent, that you should go screen this spinal cord, because this can't explain by the lesion. You said, why can explain the attacks and syphilis? I said, no, the pigment is not for you have to look for other lesions, not for that. So that you have to have a radiologist with you, you can understand, you can help you. In fact, 3 hours for somebody to do that. 3 hours. The whole day, they are all questions, it will be taking you time. But you have to first with that, you'll get the answers.
Great.
So, shall we stop or go for another case also?
I can go on for next 24 hours. It's up to you.
One more.
Okay. It is a 40-year-old man presented with this back pain in the back of the neck in a line along the back of the neck 2 days. It's not radiating. It's exactly in the nape of along the back of the neck. Pain increased over the next 3 hours. No radiating the pain. The pain increases by bending the neck and slightly increased by coughing. That is on leading question. Because referring that is bending, it is getting pain. No symptom made. Next day, he noticed weakness of the left hand, so much so he could not do anything with his left hand. No difficulty in walking or any weakness of any other legs. So while examining, I noticed wasting of the right hand and asked him what about that. He told it has been there for last 7 to 8 years, and he was not bothered about that. He came only with the present problem. However, he has no complaints pertaining to the right hand, no sensory complaint. This is the story of the patient. Just you can understand.
2 ദിവസം മുമ്പ് പ്രത്യേകിച്ച് ഒരു കാരണമില്ല. എപ്പോഴും എത്ര മണിക്കാണ് കൂടുതലായിട്ട് തോന്നുന്നത്? എത്ര മണി തോന്നി? അത് ചുമക്കുമ്പോൾ പിന്നെ ചുമക്കുമ്പോഴും തുമ്പോഴും കൂടുന്നില്ല, ചുമക്കുമ്പോഴും കുനിയുമ്പോഴും പേന കയ്യിലോട്ട് വരുന്നില്ല. പിന്നെ ഇന്നലെ മുതൽ കൈക്ക് ബലക്കുറവ്. ഇന്ന് രാവിലെ മുതൽ പേന ഇന്നലെ ഉണ്ട്. ഇന്നലെ 2 ദിവസം
freaking pain. On examination, the people was there on the left side.
compared to that.
Normal. Biceps normal. Biceps normal.
ഇതും പൊക്കിക്ക്. ഇതിനൊരു സൂക്ഷിപ്പുണ്ടല്ലോ.
The waist.
എത്ര നാളെ ഇത്
What?
കഴിഞ്ഞിട്ട്?
10 വർഷത്തിൽ കൊടുക്കുന്നു
ആ 10 വർഷമായിട്ടുള്ളതാണ്. ഇങ്ങനെ അകത്തി പിടിച്ച് അകത്തി പിടിച്ചോ. ഈ കൈക്ക് പക്ഷെ ബലക്കുറവൊന്നുമില്ല നിനക്ക്.
ഇല്ല, അങ്ങനെ
എല്ലാം ജോലിയും ചെയ്യാം.
ഉണ്ട്.
നൂർത്തെ ഇങ്ങോട്ട് തള്ളു, അന്നേരം തള്ളിക്ക്. ശരി വിട്ടോ. ഇതൊന്ന് പൊക്കി ഇങ്ങനെ പിടിച്ചോ. നോർമൽ. ഞാൻ തള്ളിക്ക്. എൻ്റെ കൈ തള്ളി അറ്റം മടക്കിക്ക്. ഈ വിരല് മടക്കിക്ക്. മടക്ക്. ഇത് മടക്കിക്ക്. മടക്ക്. പറ്റണില്ല അല്ലേ? ഇത് മടക്കിക്ക്. മടക്കി. ആ പറ്റില്ല. രണ്ട് കൈ വെച്ച് ഈ കൈ നോക്ക്. ഇത് പൊക്കിക്ക്. ഇത് പൊക്കിക്കുക. കൈ മടക്കിക്ക്. നോക്ക്. ഈ വിരല് മടക്ക്. മടക്കി വിട്ടോ. ഇത് മടക്കിക്ക്. അറ്റം മടക്കിക്ക്. പറ്റണില്ല. ഇങ്ങനെ കൊണ്ടുവരാൻ പറ്റി. ഇങ്ങനെ കേട്ടോ. പിടിച്ചോ. അങ്ങനെ പിടിച്ചോ. പറ്റണില്ല. നീ ഇങ്ങനെ പിടിച്ചോ. ഇങ്ങനെ പിടിച്ചോ. പറ്റണില്ല. ഇങ്ങനെ പിടിച്ചു. ഇങ്ങോട്ട് തള്ളിക്ക്. തള്ളിപ്പിടി. ഇങ്ങോട്ട് തള്ളിക്ക്. പറ്റണില്ല. ഇങ്ങോട്ട് തള്ളിക്ക്. വെള്ളം മടക്ക്. നോക്കാൻ നോക്കി. പറ്റുന്നില്ല. ഇങ്ങനെ ഓരോ വിരലായിട്ട്. വെരി ഗുഡ്. വേറെ മറ്റേ കൊണ്ട് ചെയ്തേ. മുടക്കില്ലേ? ഈ കാല് പൊക്കമുള്ള ഇത് പൊക്കിക്ക്. പൊക്കി മടക്കിക്ക്. ചോട്ടി മാറ്റി. ചോട്ടി ഒന്ന് മാറ്റും. ചോട്ടിക്ക്. മാറ്റിക്കോ. ഇത് ചോട്ടി മാറ്റും. മാറ്റും. ആകെ മുന്നോട്ട് എടുക്കും. ഇത് പൊക്കി പിടിച്ച് തള്ളവണ്ടി പൊക്കിക്കോ.
ലൈറ്റ് ലെവൽ എല്ലാം അങ്ങോട്ടാക്കി ലൈറ്റ് കത്തുന്നു. ഇത് കത്താറുണ്ട്. ഇത് കുഞ്ഞു കേടാക്കിയതല്ല. കത്തിയില്ല.
Normal in the right.
പനി മടക്കിക്ക്. മുറുക്കി പിടിച്ച് കൈ മുറുക്കി പിടി.
Normal.
Okay. ശരി. ഇനി ഈ കുത്തുന്നതും ഇതൊക്കെ ഒരേപോലെ അറിയാമല്ലോ. ഒരേപോലെ ചെറിയ വ്യത്യാസം പറ്റിയേക്കണം. നല്ല ഒരേപോലെ അറിയാമല്ലോ. കുത്തുന്നതും ഇതും ഒരേപോലെ, ഇത് കുത്തുന്നതും ഇതും ഒരേപോലെയാണോ? ഇത് രണ്ടും ഒരേപോലെ ഒരേപോലെ. ഇത് തോന്നുന്നുണ്ടോ? ഒരു വൈബ്രേഷൻ ഇപ്പോൾ ഉണ്ടല്ലോ. ഇപ്പോഴോ? 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 ശരി. ഇപ്പൊ എവിടെ വേദനെടുക്കുന്നത്? ഇവിടെ. ഈ ഭാഗത്ത് ഇവിടെ കുഴിയുമ്പോ ഇവിടെ വേദനെടുക്കും.
So I'll tell the findings once again. Left aneuploria, but no pupillary, no narrowing of the palpebral fissure. No normal. Power, left upper limb, weakness of the left wrist extensions, extensor pollicis longus, and all small muscles of the left hand. Please, those who are speaking, will you please mute, please? Right upper limb, wasting of the FDI, weakness of the hypothenar, all interossei, adductor pollicis, query plus digitorum longus and middle two fingers. Both lower limb normal. Deep reflexes, left upper limb, biceps diminished compared to the right side. Left biceps absent. Right upper limb and both lower limbs normal. Abdominal sensation common known during it with the left. Now,
What was his main complaint, Madhu? Weakness?
In fact, he complained of a pain in the back of the neck, linear pain, that is increased by flexion, but not increased by popping and sneezing. And that is one day. Next day, he cannot use his hand at all.
No, it was an acute onset problem.
Yeah, acute. Next day, he cannot use his left hand, but no sensory complaint in the left upper limb, no dysphagia, and left lower limb.
But onset is acute.
Acute. Next day, he noticed. First day, he had pain in the back of the neck. Next day, he had the weakness of the left hand.
Left C8 root involvement, but the left triceps is not involved, sir.
Yeah, C8 involvement.
But triceps is spared, sir.
Well, he has got weakness of the wrist extensors, finger extensors, finger flexors, all weak. The right hand is also weak. Right hand has weakness and weakness, but the duration, he noticed the weakness right hand 10 years back and never bothered. The present problem with the left hand.
Intramedullary.
Intramedullary lesion. Okay. Any other possibility? Anyone? Any possibility?
CV junction.
CV junction. CV junction is less likely because he has got reflexor or diminution on the left side.
Are the problems on the right and left side related or different?
That you have to find out. Patient in front of you. You can't ask the patient is related or not.
Maybe it's related, so it's an intramedullary lesion. Normally, it's one.
But what the less likely related there because that problem gives It's not, he never came to me with that problem. It was, he's in the Smith for 10 years and never bothered him. As Paul said, this occurred rapidly, acutely on the left hand. So most likely this is unrelated. Logically, it is unrelated. Even
Maybe
though,
a syringe which suddenly increased in size.
but in that case, should have been more on the right hand. The syringe was implicated on the right hand, causing the weakness. Should have worsened on the right side. We came with only left side.
We don't know whether it has worsened because the symptoms are already there. We haven't seen him before, no?
He said this wasting has been there for 10 years.
But has a weakness worsened on the left side, on the side which has the wasting?
No. He is not complained regarding the right upper limb at all. I picked up the wasting, asked me what happened. He said this has been there for 10 years. Do you have any problem with the right hand? No problem with the right hand. Examination weakness of the
present problem is in the left hand.
correct. Present problem is the left hand.
In the left hand, so the previous what you noticed was the some chronic problem in the right hand.
Right hand.
But so you know, logically or intuitively we would think of a disease there only at that point.
Yeah.
You know, maybe some disc disease or something there, chronic cervical canal stenosis or something with a disc problem.
Okay. Let us see now. Then the present problem is what's the problem in the right hand is the question. Now what do you want? I'll take the answer later on.
MRI.
MRI.
Oh, the cervical spine?
Yeah.
Okay. Then my question was somebody said CA-driven radiculopathy. But CA-driven radiculopathy cannot explain the weakness of the wrist exercise.
Wrist extension, yeah.
Cannot be explained by a CA-driven radiculopathy. You can explain by active finger flexors, you can explain small muscles, you can explain, but not finger extensions and wrist extensions. It has to go up to C7. So in C7, C8 can explain. See, all the muscles separated by the D1 are also separated with the C8, but the relative content may differ. The only muscle which is almost exclusively separated by the D1 is the abductor pollicis spinalis. All other muscles contribute to C8 as well. So at least we have to implicate C7 and C8. Okay. So correctly, I'll show that MRI picture once again. Is the D1 made axial cut. You can see the disc there, but in better scale the T2 is drawn. This is the T2 weight is taken. No. That's the level of compression. See the cord and is getting compressed there. Compression there on the left side. Compression again, you can find out. I'll show this one second. This is a set of compression. This one. Again, the disc material protruding parasite. So it's a left C7 large heavy. Now, question now is why is that statements produce so much amount of weakness, including the C7, C8, and probably D1. Usually, if we won't get such an event,
Report ischemia.
Okay. Theoretically, can say like that. Nothing there in the MRI to find hyperintensity in the cord. and that whatever lesion is seen was only outside compressing it. So, you know what is prefixed chiasm and the post-fixed, not chiasm, like prefixed brachial plexus and post-fixed brachial plexus. Sometimes the brachial will be contributed mainly by the roots above that, C4 to C8. In that case, the lesion may, the distillation may be compromising the roots little high. Okay, so that possibility you have to keep in mid such situation. Anyway, you remember that one level difference and not can occur with any disc collapse. Now, any other investigations you want?
No conduction.
No connection.
For what?
For the right hand wasting.
Because for the right hand, the distribution muscle weakness exactly in the ulnar, even though he has a complaint on the right side. The weakness was the ulnar distribution, the interosseous adductor was, and very weakness on the middle to present muscles. So he was damaged. I forgot the node got unlearned on the right side during sense. Let us see that.
ഇത്രയും വരത്തുള്ളൂ.
What do you find? You cannot extend it.
ആക്സിഡന്റ് പറ്റി എത്ര നാൾ മുമ്പ് അത്?
8 വർഷമായി.
Is very angry. The right side. And he had an injury to the elbow 10 years.
The injury to right elbow.
Yeah, 10 years back. So what?
That can explain tardy ulnar.
That's a tardy ulnar palsy on the right side. Presently has come with an acute dysplasia causing and a weakness on left hand without any sensory complaint. That's a problem. So in fact, one may even, because the reflex loss we suspected it. Otherwise, you would even think of a cortical lesion also. The pain and the sensory, pain, onset of the pain was sensing a cervical cord. If that was not there, it was mimicked a cortical lesion.
Which was disc which was prolapsed, sir? C67.
C7.
C67.
C6, C7.
That would catch the 7th nerve, no? 7th root, no? So the 8th is you are implicating the post-fixed or?
Yeah, post-fixed. Someday, or this can also someday migrate down to implicate the joining root. But here, the root involvement is slightly on. That's the point. Okay, any questions? Now, this case, what because of that right upper limb weakness was confusing us. Or it's related or not, unrelated or not.
But Madhu, you said that this right hand weakness was because of the ulnar nerve?
Yeah, ulnar nerve.
But it was a pure motor ulnar nerve, right?
Pure motor ulnar. But electrologically, he had sensory involvement as well.
Sorry?
NCV showed sensory impairment as well on the right side.
No. How do you explain the no loss of sensations?
Maybe the motor vulnerability is there. No? Some even radial pulses, sometimes they come with motor weakness with the sensing, pressure pulses sensing.
Okay.
Maybe the motor fibers are more vulnerable to that.
Okay. Yeah. Okay, Madhu. Thank you.
Okay, thank you. Thank you all for patient listening.
Thank you so much.
Thank you. Thank you. Next Sunday.
Thank you, sir. Thank you very much.
Thank you, sir.
Thank you all.
Thank you, sir.
Thank you. Thank you, man, sir.